Good morning, everyone. My name is Dr. Susan Adebato. I'm a New Jersey licensed psychologist working at the New Jersey Medical School in Newark, and I'm the director of the Fetal Alcohol Syndrome Diagnostic Center and the New Jersey Northeast Fetal Alcohol Spectrum Disorders Education and Training Center. Today I'm going to spend some time talking about prenatal alcohol and fetal alcohol spectrum disorders. The first thing I'd like to discuss is how much it costs the United States per year to treat an individual through a lifetime. Literally, it can cost from $870,000 to as high as $4.2 million for one person over a lifetime health cost. So we're talking billions of dollars that the United States spends each year trying to deal with this disability. The quality of life for these individuals are often reduced 17% or 11 years. One might think, well, I don't understand why does it cost so much? This slide tells us why it costs so much. This is Brandon. Brandon is the adopted son of Julie. They live in Seattle, and Brandon is Native American, and he also was prenatally exposed to alcohol. When he was in his elementary school years, Julie put this slide together so that other people would understand how many different health, education, and community services are often needed for one individual. When you look at the developmental disabilities that Brandon has, he wears glasses, he has articulation issues, his IQ probably is around 65 or 70, and he has attention deficit disorder. So for a child like that, these are all of the services needed through his elementary school years. On the left side are all the health and allied health. Middle is education, including psychologists, occupational therapists, counselors. And on the far right are social and community services, including tribal services, which Julie wanted to keep in place so that Brandon had a sense of what his family ideology was like. Down on the bottom, legal and financial services. Many of the children who are prenatally exposed get in trouble with the law, but for Brandon, at this point, he just needed services such as SSI, Medicaid, and adoption support. A basic definition is always needed in a workshop like this, and I want to tell you what the standard drink is. Many of us have our own ideas of what a standard drink is, but this slide tells you what a standard drink is. 12 ounces of beer or wine cooler, a 5-ounce glass of wine, and a 1.5-ounce glass of liquor, which would be a shot such as Jack Daniels, vodka, anything like that. That is considered a standard drink. When you are dealing with women who have alcohol issues and are struggling maybe with alcoholism or just drinking too much, their standard drink may be much, much higher. But this is what a typical standard drink should be. And for the unborn child, it's truly the alcohol in the drink that harms. There's a lot of information regarding the other substances, the illegal substances such as heroin or crack cocaine. But what we're finding in the research is that it's the alcohol that by far causes the most deleterious, lifelong damaging effects. This slide looks a little busy, but you just need to know this in order to understand how alcohol affects the brain during development. This slide shows you fetal development. On the left side, these are all in weeks. On the left side, the first 2 weeks, what usually happens is if a woman has drank before conception, most of the time, it's a teratogen. Alcohol is a teratogen. It's a poison to the brain. It's not usually susceptible to teratogens in the first 2 weeks of pregnancy. What happens once the egg implants itself in the uterus, then all bets are off. Anything can happen regarding the prenatal alcohol use. So if you look at the top line, the red is the congenital anomalies and the structural issues. The gold or yellow is the functional defects. So you can see that throughout the weeks of pregnancy, the face develops very, very early in the pregnancy. And by about the 56th day or so, the entire format for the entire structure of the body is made. Can it survive outside the uterus? No. It's about as big as a pea or a raisin. So it certainly can function, but the format is there. And if any of you know anything about fetal alcohol syndrome, it's probably that there is a distinctive facial criteria and facial features, and that happens very, very early in the pregnancy. So another question you might have is, I don't understand. My mother drank, my sister drank, my cousins drank, or whatever, and how come their child doesn't have any issues? And this is the slide that tells us why some women who drink prenatally will have a child with prenatal alcohol issues and some won't. It depends. It depends on the dosage, how much the woman is drinking, her pattern of drinking. The more she drinks, the more she's likely to have a child with prenatal alcohol issues. If she's binge drinking, that we now know through research is the worst of all. For a woman, Binge drinking is more than 3 drinks at one time, at least once a week. Timing during gestation. Different things are happening during different times in gestation, whether it's structural, whether it's functional, or whether it's the central nervous system or the liver or the kidneys. Different things are happening. So the timing during gestation will affect different parts of the child's development. Advanced age. We know that the older the woman is, if she's drinking, then the more likely she is to have a child with problems due to her drinking. Genetic sensitivity. This is not a genetic disorder. However, we do know that females have there is a genetic sensitivity. We do know that it runs in families, and women, more so than men, are more sensitive to drinking. We are more likely to get sick and possibly die if we if we drank too much. Maternal metabolism. That's a chronic use of alcohol. A woman who is used to drinking, she can drink more than someone who doesn't drink at all. So clearly, if you drink more, then the likelihood is that chronic use of alcohol will lead to possible effects in the developing fetus. Nutrition and parity. If you are drinking with your first child and continue to drink with every other pregnancy, then again, there's an increased likelihood of each child being affected. The active teratogenic metabolites, synergy with other agents, environmental things, I like to call it a perfect storm. Everything has to come together in order for this child to have prenatal alcohol influences. And there are a lot of things in the environment, certainly here in New Jersey. We are Superfund, we have lead, we have mercury, we have other things that the woman is exposed to, and this all could combine to cause the damage that alcohol in and of itself might not cause. And of course, there's always mental health issues that can also add to the issue and the problem. This slide just tells you that you don't have to drink a lot. Even low levels of prenatal alcohol consumption have been associated with long-term measurable effects with Dr. Day and Dr. Sood. And the current alcohol use among pregnant women between 15 and 44 is estimated at about 12%, and binge drinking at 3.9%. So that little 3.9%, that's the possibility of the child being even more damaged with the drinking. So what does alcohol do? It crosses the placenta freely from mother to fetus. The fetal liver can't metabolize alcohol as efficiently as an adult. What happens if you think about 1 ounce of alcohol takes 1 hour for us to excrete it, to us to deal with it, that fetal liver is not as efficient. It's a maturing organism, so it takes longer for them to deal with it. Depending on if mom is binging, it could take hours, even days for that. This is a slide that tells you what happens in the different trimesters. The first trimester, as I said, you have the facial problem, the substantial structural changes. Brain damage occurs throughout the entire pregnancy, and there's also cellular damage. The cells could die out earlier, they could migrate wrong, they could differentiate inappropriately. Second trimester, what happens with, there's increased risk of miscarriage or spontaneous abortion. There's poor nutrition, so you can have the restriction of growth of tissues and organs. And by the third trimester, a lot of our women have been told by their physicians it's okay to drink in the third trimester, you're only putting weight on the baby, but that's not really true. A woman who drinks in the third trimester has the potential to have lower birth weight or lower overall amount of growth, increased likelihood of early labor and delivery, and intellectual disability. The IQ is compromised. What does prenatal alcohol use to the developing brain? Well, unfortunately, research shows us anything it wants to. This is a picture of the brain and each of the different sections of the brain, and each section, depending, if you remember back to that slide where I showed you where the different things are happening, depending on when mom is drinking and how much she's drinking, anything can happen to any part of the brain. And with that, that's why we can't cookie cut our interventions or a treatment, and that's why we can't tell you if mom drinks 1 drink in the first trimester and 2 in the third, then her child will have X, Y, and Z. It doesn't work that way. If the mom is drinking when any of these brain regions are affected by the alcohol, you have different outcomes. It can affect movement and cognition if it's the basal ganglia, or the hippocampus is the memory. Corpus callosum, a lot has been done with the corpus callosum. If you go back to your Psych 101, that's that area in the middle of your right and your left hemisphere, which it's literally like, I call it the traffic cop. It tells what the right and the left is doing. So it's really important to understand that at any point in the pregnancy, if mom is drinking, theoretically something can be causing damage to the developing fetus. So let's get another basic definition. What is fetal alcohol syndrome? Fetal alcohol syndrome is a lifelong birth defect caused by mom drinking during pregnancy, period. You can't catch it. It's not genetic. If I have fetal alcohol syndrome but I don't drink during my pregnancy, my child cannot have it. If dad is drinking, the child will not have full-blown fetal alcohol syndrome, but research tells us that if dad is drinking at the time of conception, then the children are born smaller, and there can also be learning disabilities as well. So here's what the diagnostic criteria. We have 6 diagnostic centers here in New Jersey, which I'll be talking about a little at the end of my talk. Not many physicians are qualified or know how to look at the diagnostic criteria. So it's important that you get the child, if you think that if you know there's prenatal or there's a possibility of prenatal alcohol consumption and they are showing some of the disabilities, that you get them to a diagnostic center. And these are the 3 things we look at. One is growth restriction. These children are born smaller and they usually stay smaller throughout birth, through the remainder of their life. Some will catch up, but for the most part they remain small. Some of them also have small heads. Central nervous system, I'm going to get into that in another slide, but there could be anything from intellectual disabilities, developmental delays, learning disabilities, poor coordination. The face is really one of the distinctive features that we look at in order to differentiate fetal alcohol syndrome from any prenatal alcohol exposure, which would be fetal alcohol spectrum disorders. And this is the face that we look for. If you look on the left, there are 3 things that we measure, and we use something called the 4-digit code here in New Jersey. It was developed by Susan Astley a few decades ago, and it's the most precise diagnostic model we have. There are about 4 that we can use in the United States, but we've chosen to use this in New Jersey. The first thing we look at is the eyes. They have short palpebral fissures, which are very small eyes, and we measure across the eye, each eye. Then we look at the space between the nose and the mouth, which is your philtrum. It's very flat and what we call indistinct, and then there's a thin upper lip. Those are the only 3 things that have been shown to be significant in this diagnosing for discriminating features in prenatal alcohol exposure for fetal alcohol syndrome. There are other features that you can see in the discriminating on the left and associated features on the right, but those are the only 3 that we look at: the short palpebral fissures, an indistinct philtrum, and a thin upper lip. This is a young man. This is a relatively new diagnosis. We're celebrating, I don't know if you can say celebrating, but we're commemorating the 40th anniversary here in New Jersey in September. In 1973 was really the first article that came out in the United States that described fetal alcohol syndrome, and this young man is from back in the 1973. So you can see that his eyes look big, but if you were to measure them, they are short. He has no philtrum, and his upper lip is very, very thin. So, fetal alcohol syndrome is really only a tip of the iceberg. When you look at statistics, it's maybe 1 to 3 per thousand. Some people put it as high as 3 to 5 per thousand in the United States, and it's like an iceberg because most of the individuals that you will come in contact with your work and I see at the Diagnostic Center have fetal alcohol spectrum disorders, which is a descriptive term with confirmation of alcohol, and it includes diagnostics that include fetal alcohol syndrome, partial fetal alcohol effects, alcohol-related neurodevelopmental disorders, and alcohol-related birth defects. That would be about maybe 20 to 35 per thousand. So there's more children and adolescents and adults because this is a lifespan disability that you'll see in your courts, in your programs, in your services. Now what I'd like to do in the next few minutes is just very quickly go over 10 domains that we look at and that you can put in your head to see if this child has any disabilities related to the prenatal alcohol. One is cognition. So you can look at intellectual functioning. They may have an intellectual disability. They may have developmental disabilities or learning disability. About 68% of the individuals have activity and attention issues, so they may come into our Diagnostic Center with ADHD, or we may give them that diagnosis. So you do have the classic hyperactivity, the difficulty focusing, though many of the individuals with alcohol have the focusing problem that they are kind of focused outside of what's going on. So they may be looking out the window, they may be thinking to themselves and daydreaming. That's more likely the case. There's also encoding and shifting problems. Encoding is when we make notes, you're listening to me, you're looking at the PowerPoint, so you may be making some notes, putting it in your own words or your own shorthand so you remember it for tomorrow, next week, or next year. Shifting, we should do that all the time, mentally shifting from one thing to another or physically shifting. They have a hard time doing that. They're slower to do that. Learning and memory could be any problem. Auditory, spatial, design, narrative. Working memory, it's short-term memory. So therefore there's maybe intrusions, there may be perseveration problems. If you're dealing with school-age children, there could be problems with their comprehension and math reasoning in school. Executive functioning is really where a lot of the issues are. What is that? It's everything we do. It's our planning, our organization. It gets you where you need to go every day. It keeps you there until you're finished and then you move on. It keeps you regulated emotionally. You're not impulsive. Most of us are not impulsive or labile in our moods, and it's our abstract thinking. They have a lot of difficulty with that. Sensory motor integration is very similar to ASD. They can be hypersensitive or hyposensitive. Also, social skills and adaptive behavior, they don't, because of the brain damage, they don't read situations correctly. So they may be misreading cues, they may not be able to read cues and gestures, and that's what gets them into trouble, especially with the law. They don't understand what's going on in the situation. And any mental health issue that's in the DSM-5 could be a possibility co-occurring with prenatal alcohol. Because we're concentrating on infants and toddlers, I just wanted to put two slides up. One is on infants and one is on toddlers. When you're dealing with infants, these are just some of the developmental issues that they might have. One is poor sleep-wake cycle, similar to other substances. They're very irritable, they take cat naps, they may have poor weight gain, they have chronic ear infections and chronic immune problems, maybe difficulty nursing if they have structural issues. Some of these children, if their mom binged in the last trimester, have cleft lip and palate, so they may be difficulty nursing because of the structural and of the lip and cleft palate. They may have difficulty bonding with their caregiver. They may have developmental delays, speech delays, low muscle tone. So there's a lot of developmental issues that are occurring in infancy. With toddlers, some of them are classic in terms of there may be delay in potty train, there's going to be continued motor delays, continued developmental delays. Now you're starting to see they're easily distracted. There's a lot of colds, infections, and other illnesses, so the immune issues may continue. Eating. They have very small appetites or sensitivity to food texture. Maybe they'll only eat anything that's mushed or anything that's salty or crunchy. They're very fidgety. Parents will say they're constantly moving, they're falling off the chair, they're swinging their leg. I can't keep them still at church or in a structured event like that, and they have sleep problems that will continue. So these are just some of the things that you can see in infancy and toddlerhood. I would not wait to see if they grow out of it. It's very important to get them to a trained diagnostic service agency that can help you kind of tease out if there are delays and if the disabilities that you're seeing are possibly related to the prenatal alcohol. So what does this mean in real-term life and everyday life? Well, think about it. If you have impulsivity and poor self-regulation, what's going to happen? You're going to have a decreased tolerance for frustration, and these individuals are going to be very quick to anger. If you have poor habituation, you're going to be constantly overloaded with stimulation. You may shut down, you'll behave irrationally because you don't know what that situation wants from you. And perseveration, you'll continue to do the same thing over and over again because you can't really remember what works best in this situation, whether it's right or wrong, whether it's successful or not. Poor judgment. This is what gets them into trouble with the law, particularly. They trust anybody. They will go with anyone. If someone tells them go into that candy store and get me a candy bar and doesn't give them the money, they'll go in and get the candy bar. They don't understand, I need money to pay for that. Difficulty with self-reflection. If they don't have a good self-concept of what they're feeling, how they're feeling because of the brain injury, they may not be able to express their needs and they may have difficulty getting help. These are just some of the disorders identified with FASD, so you can look at this at your leisure. I can tell you that anything that's in the DSM-5 can be a co-occurring, which means it occurs in addition to the prenatal alcohol. The problem with you need to know whether or not this child truly has prenatal alcohol exposure because that may affect the medication that you want to use, and it can also affect your traditional therapeutic interventions may not work. So what does work? Dr. Streiskuth is a psychologist who's been working on this since 1973. She's done a number of books and articles, and she says the best way to protect these individuals throughout a lifespan is early diagnosis as early as you can, stable, nurturing home environment, and I know that that's not always the case, but even if they're in a home for a few months or a year, if it is stable and nurturing, that child will do better than in a child who's continually moved to an appropriate house, inappropriate foster or adoptive care. No violence or victimization. That means witnessing it or being a victim themselves, and any type of early services, whether it's early intervention, whether it's Division of Developmental Disability. For our older individuals, remember that adults can also have prenatal alcohol, so some of the caregivers that you're working with may also themselves be struggling with prenatal alcohol, so they may need services themselves. I don't have time to go into what works best, but this is a very good slide to use. It's by Teresa Kellerman, who's an adoptive mom of a young man who's now in his 30s, and she wanted to scream because she knew he had prenatal alcohol. She knew he had issues, but what did you do? No one was telling her what to do. So this is very quickly telling some general intervention practices. Structure. Get a regular routine. Simple rules, concrete. One step at a time. Use cues. If they can use verbal, visual, or symbolic reminders, whatever they need to help counter the memory deficits, use it. Role models. Be careful who they're friends with. Be careful the TV. Be careful the websites that they're able to get in. Environment, keep it simple. Low sensory stimulation modified to meet their individual needs. Understand that it is due to brain dysfunction. It's brain damage. It's a functional brain damage. You may not be able to see it on a CAT scan or other brain scan, but trust me when I say it's a functional brain damage. And if you understand that and use that as your attitude, you'll go far with the interventions and assisting these individuals. Medications, I already just mentioned that you need the right combination of medications. So we need to be careful with that because sometimes the medications that we think help has the exact opposite effect, and supervision. They need 24/7 monitoring, some for life due to their poor judgment and impulse control. Not everyone needs to go into a residential care, but many still will need what I call an external brain to help them through the tough times. These are just some other guiding principles that you can also look at your leisure. I like to put this so that you understand. Think 2/3 chronological age, and then you'll get where this individual is functioning. Try to foster interdependence and always respect. Remember that it's not something that you can catch. It is something that they had prenatally. Some people think it's a non-compliance. If you shift from non-compliance to non-competence, sometimes they are non-compliant, but for the most part, they're non-competence. They do not understand what is happening. They do not understand what is needed in a certain situation. They're doing the best that they can with what they've got. And you always have to believe that you can make a difference with the individuals with prenatal alcohol exposure. Here's just some additional tips. Again, concentrate on their strengths, accept their limitations, be consistent. I can't tell you how consistency can truly, truly help. Repetition, repetition, repetition is the key. Very quickly, I would like to tell you that there's 6 regional diagnostic centers for fetal alcohol syndrome, 2 in the north at my New Jersey Medical School in Newark, and at Chat, which is Beth Israel across the Newark near Irvington, 2 in Mid-Jersey. 1 is at Children's Specialized in Mountainside. 1 is at Jersey Shore. And then there are 2 all the way down South Jersey. 1 is at CHOP in Mays Landing, and 1 is at Little Egg Harbor, which is a new site, which is the Children's Specialized site that just opened up a few months ago. We all do the same thing. We all work on a comprehensive assessment and management of individuals with fetal alcohol syndrome. We are all child evaluation centers that also have fetal alcohol syndrome diagnostic centers. We all have developmental pediatricians that first see the child. Anyone can be evaluated by us if you at least think there might be prenatal exposure, regardless of ability to pay or disability. We will see them. They're first seen by a physician, which are pediatricians, developmental pediatricians. Mine just happens to be a geneticist as well. From there, depending on the age and depending on what evaluations and services they had in the last year, they may see a psychologist, a speech therapist, an occupational therapist, physical therapist, learning disabilities, or psychiatric psychiatrist. Then from there, remember, we do not do treatment at our programs. We are a case management model, so we will do the diagnosis. There are, with the 4-digit code that I mentioned that we use, there are 22 possible diagnoses. We look at the confirmation or non-confirmation of alcohol, the central nervous system disabilities, the growth restriction, and the facial characteristics, and we put that together, that combine it to 22 possible diagnoses, and then we case manage. As you know, we have 21 counties in New Jersey, so some counties are better than others in terms of what services they can offer. Depending on the age and the needs of the individual, they may need early intervention or just tracking. They may need medication. They may need support services, whether it's vocational, educational, special education, supervised housing, or vocational rehabilitation. So we also will try each of the diagnostic centers. Once they do the diagnosis for you, they should be able to case manage that case in whatever county they are working with. You can go anywhere to each of the 6, but we prefer that you stay within your county area. So I very quickly went over what happens with prenatal alcohol exposure. I want you to be very, very clear. This last slide is very important. It truly is that a few drinks can last forever. There's no safe time. Any time in the 9 months, a child can be prenatally exposed to alcohol, and it can cause damage if mom is drinking. No safe amount. Anything that mom drinks theoretically can cause problems. Binge drinking is worse, and that's 3 or more drinks at one time, at one sitting. And no safe alcohol. A drink is a drink is a drink. Doesn't matter if it's micard lemonade, a mojito, a shot of vodka. Alcohol is alcohol. So what I usually say is, if you are of childbearing age, pregnant or thinking about getting pregnant, or working with women of childbearing age who are pregnant and thinking about getting pregnant, you should either contracept or don't drink, period. It's not worth what I call the roulette wheel of whether or not your child will be one of the ones who do not have any problems or do have problems related to the alcohol. So my strong recommendation is, with this information, please review it. If you have any questions, you can certainly contact me. My email is on the first slide. I would be happy to answer any questions for you, do extra training for you, or to just work through cases if you don't know where you should refer these individuals to.